Welcome back to ISNTD Climate and Health. This is the first conference by the International Society for Neglected Tropical Diseases on climate and health, and kind of the linkages and the evidence on the impact of climate on diseases, and particularly tropical diseases. We've had two really fascinating days, 6 sessions so far, exploring everything from the basic science, impact of climate on vectors and on parasites, but also all the way to the other spectrum, advocacy in these fields, and also methodologies of how do you break down the silos between the field of climate and the field of health. And I think the message that's been really clear throughout all these sessions and these 2 days and the wonderful presentations we've heard from colleagues around the world is that the field of tropical health has a major part to play when it comes to mitigating or responding to the climate crisis. And so to conclude this really exciting and important event and all the discussions and the thoughts that we've been exploring all along, we really wanted to put the focus on the field of tropical diseases as a major stakeholder in climate. And so it's my great pleasure to welcome this final panel and our 5 fantastic speakers who will be taking us through all these various aspects of how can we respond and how can we be a really important part of responding to the climate crisis, whether that be in terms of R&D, whether that be in terms of vector control innovation, whether that be in vector repellents, and just more generally as part of a humanitarian response when an extreme climate event happens. So without any further delay, I'd like to welcome very warmly our speakers. First and foremost, we'll be hearing from Dr. Somia Iqtadar. Somia, welcome.
Thank you. Thank you for inviting me.
Thank you so much. We've spoken a few times at an ISNTD event. It's always a real pleasure to have you here. You are assistant professor at the King Edward Medical University in Pakistan, and you're also with the Dengue Expert Advisory Group, the DEAG, in Pakistan. So thank you.
Yeah, but you have the old introduction. I've been promoted to the head of department and associate professor.
Well, okay, congratulations then. I take this opportunity. Thanks for clarifying that. So it's a great honor. And then we will also hear from Dr. Prasad Liyanage. Welcome, Prasad.
Hi, Sonia. Thank you for the introduction. Hi.
Thank you for joining us. You are representing the National Institute of Health Sciences in Sri Lanka, and you'll be talking to us about the relationship between El Niño Southern Oscillation and Aedes vector activity. We look forward to that.
Yes.
A very warm welcome as well to Dr. Emma Maynard. Hello, Emma.
Hi, thank you for having me.
Thank you for joining us. So you're from the Wellcome Trust based here in London, and we heard a lot from your colleagues already from your very exciting work individually and as an organization in this. And talking to us about insect repellents and the preventive side of tropical diseases in terms of climate change, it's a real pleasure to welcome Dr. Delali Manto, representing Merck. Hello, Delali.
Hi everyone. It's a pleasure to be here.
Nice to have you here. And finally, to talk to us a little bit more about R&D and developing therapeutics for climate-sensitive neglected diseases and some of the challenges that this represents. It's a pleasure to welcome Professor Kishore Vasan. Hi, Kishore.
Hi, nice. Thank you for having me. Pleasure.
Thank you for joining us at this ungodly hour for you, I'm sure.
Yeah, it's a little early in the morning here, but that's okay.
Oh gosh, that's what I call dedication. You're co-director and co-founder of the Neglected Global Diseases Initiative based at the University of British Columbia. So thank you so much for being here.
Pleasure.
So without any further delay, I'm going to hand over the floor to our speakers. And first and foremost, we'll be hearing from Dr. Somia Iqtadar, who'll be talking to us about going from extreme climate to public health in a crisis, and the impact of the devastating floods in Pakistan earlier this year.
Thank you very much. Good morning, good evening, and good afternoon to all the audience who are in different parts of the world. Ladies and gentlemen, water is the driving force in the nature. It's the lifeblood of humanity. Our nations, our economies, and our well-beings, they all are, somehow dependent on water. And water is a sign of life. It's a sign of love. It's a sign of happiness. But sometimes, whenever there is extreme of anything, then this becomes a crisis. And this is exactly what happened in Pakistan this year, when there was excess of rainfall in different parts of the country, leading to flooding all over the province, especially in provinces of Balochistan, Sindh. There were a lot of flooding, and because of the unprecedented, a lot of catastrophic. I'm going to talk to you from extreme devastating floods in Pakistan. As mentioned by Marianne, my name is Dr. Somia, and I am currently heading the Department of Medicine at King Edward Medical University. I've been associated with Dengue Expert Advisory Group for a very long time, and I've chaired it previously, and I look after the infectious diseases. And I'm also the founding Secretary General of Pakistan Society of Internal Medicine. And it's an extreme pleasure to be here on this Climate and Health conference webinar today to talk about some of the effects of climate change, and which we have experienced because of unprecedented heavy rains during the year's monsoon, which have caused massive destruction. So this massive destruction and this unprecedented downpour is actually because of the climate change. The severe heat wave, followed by 30 years of record-breaking rains and glacier lake outburst flood, contributed to water levels which rose in the dams and rivers and ultimately resulted in floods. And this has been labeled as the world's deadliest flood since the 2020 South Asian floods that you remember. And another contributing factor for worsening the floods in Pakistan has been the deforestation. And Pakistan is the 8th worst affected by climate change phenomena, despite the fact that it's contributing only 1% to the global greenhouse gas emission. So the major affected areas, as I told you, that it's a widespread calamity, and it is mainly involving most of the parts of the country. But there are 3 provinces, Balochistan, Sindh, and Khyber Pakhtunkhwa, which are more affected, and more than a dozen districts are affected in KPK, about 23 districts in Sindh, and 32 districts in Balochistan. There are floods in other provinces as well, but they are not so severe. So, giving you the idea of Pakistan, we have 5 provinces: Sindh, Balochistan, Punjab, KPK, and then there is AJK, which is Azad Jammu Kashmir. And there is a region which is known as a Gilgit and Baltistan region. And if you can see, there are more than 71,000 families and 0.5 million right holders in 27 districts which are affected by these floods. And I'm going to share some of the facts and figures with you about how many people are displaced, how many had to be migrated, and what is the effect in cases in these districts in the public health sector. So this is the situation in many of the parts of the country right now, where you can see that they are flooded entirely. The houses have been destroyed completely, that have been wiped out. The infrastructure of roads and healthcare facilities is destroyed, and people are now living in camps as migratory colonies are formed by different NGOs and government sector. So this is the sad state of affairs that we are. 33 million people, they are affected due to this calamity, and about 7.9 million people are displaced. And we've been able to accommodate majority in the relief camps, but we have lost many people, with around 1,717 casualties and about 13,000 injured people. And apart from the loss that we have in the form of land and everything, the healthcare facilities which are catering to these towns and these flood-affected area, which is around 2,000 health facilities, they've also been damaged during this calamity hit. So the effects of flood can be manifold. You all know it can affect our economy, it can affect our people, it can affect the general well-being of the patients, depreciation in economy, it can lead to inflation, it leads to unemployment and poverty rate. And this flood has caused a major damage to our economy in the form of estimated damage worth of about $40 billion, 2.1 million houses damaged, 4.4 million acres of crops and orchards damaged, and schools and healthcare facilities have also been destroyed during this calamity. And this has become the talk of the international media as well. And wherever now the Pakistan is quoted these days, it is because of these floods. And World Health Organization sounds alarm on Pakistan when it says that there's a warning of major outbreaks of diseases after the floods wreak havoc. So this is something which is an area of concern for all of us, because of the interruption in the health service delivery, there's a risk, and there is not only a risk, but at the moment there's an outbreak of waterborne diseases. And the resultant outbreaks are because of many contributing factors. The first and most important one, obviously, is the damage to the entire infrastructure of the health, which is affecting the health service delivery system. But also there's disruption of the immunization services. In Pakistan, we have a door-to-door campaign for different kinds of immunization, which are part of extended program of immunization. So because of the damage to the access roads and infrastructure, there is a major interruption in this delivery system. Then the people who have been displaced and they have been placed in the relief camps, there's no proper system to address, and there is lack of facilities, so they are also suffering. Also, there is non-availability of potable water, and because of, again, the damage to excess of roads, there's delayed medical supplies, and there's lack of wash facilities, which are aggravating these disease outbreaks. So whenever there is flood or whenever there is collection of water, there's always a risk of water and vector-borne diseases. And these are the diseases which are most common in now residing in our country as well. And apart from these water and vector-borne diseases, we are also having a rise in the newborn mortality because of the poor mother and child healthcare facilities and because of the females who are pregnant who are struck by this calamity. So when I talk about diseases related to water, there can be waterborne diseases which are spread through water, like cholera or typhoid or bacillary dysentery or diarrheal disease. And then there are water-washed diseases like skin diseases, like scabies, like eye diseases, conjunctivitis, and trichomas. And then flea and lice and tick-borne diseases, they are also on the rise because of the water-washed system. Then the water-based diseases, they are sometimes also reported, but now we've not been able to report this from our country at the moment. And the biggest threat, and which is the major concern for all of us, are the water-related vector-borne diseases, which includes, in our part of the country, malaria and typhoid. So these are all that we are encountering these days, and we need to have a plan in place to address them effectively. Coming on to the disease data, I'm not going to show you each and every figures because they are collective in different parts of the country, some from the provincial level, some from the flood-affected areas. But what I can give you as a summary is that the number of cases of malaria and dengue, which are both waterborne diseases, have increased manyfold as we compare them to the previous years. And there are also increasing number of skin diseases which are reported in the flood-affected areas. And there is a reported surge in the typhoid, cholera, diarrhea, hepatitis A, leptospirosis, and also polio, which is also one of the biggest threats to our country. We are one of the two countries where still polio is residing because of the interruption in the polio workers, access of the road to the areas, we have seen a rise in the number of polio cases as well. This is the disease of the data. If you can see that we have a higher number in malaria cases because of this stagnant water and water collection because of floods. Similar is the case with other diseases like dengue. We are having an epidemic in almost all parts of the country, and the flood affected areas are having a very, very bad epidemic with thousands of cases reported from different parts of these areas every day. Coming on to the other diseases like cholera, dysentery, fevers of other origin, chest infections, skin conditions, they are also on the rise as the data shows. So we have a system of reporting from different parts of the country on a provincial level, and they are then consolidated into a data. And the data is showing the number of cases of all these problems have considerably increased in the past 1 month or so, which is post-flood, if we compare them to the yesteryears. This is another graph which is showing you a rise in the number of dysentery, acute watery diarrhea, and respiratory illnesses in Pakistan and different parts of the country. The malaria cases similarly are not only rising in flood-affected areas of Sindh, but they are also rising in Balochistan district, which is also one of the districts which is badly hit by floods, and there is the high positivity ratio of malaria cases in these regions. This is also Balochistan. We have like this data for age and gender wise in Balochistan as well. So coming on that what we need to do because of this climate change and downpouring and excess of rain and flooding, now comes the solution part. What can we do? So the first and foremost, according to me, is the allocation of resources and establishment of command and control system. And then to further decrease the risk of outbreaks, we need to drain this flood water on an immediate basis and restore the displaced population into their place of origin. But obviously, it's easy to say, but very, very difficult and very cumbersome to implement. But the government is trying on its best, along with the disaster management department, irrigation department, the CNW department, and different NGOs and different world organizations which are helping our countrymen in this difficult times, and we are trying to mitigate these problems. Another mitigation strategy that we need to focus on is the public health measures, because the infectious disease outbreak is the resultant of all these floods and calamities, and the public health measures to prevent and control the communicable disease is the need of the hour. And then for improving the public health in general, we need to restore the damaged health-related infrastructure and ensure the continuity of the supply and delivery chain related to the medical facilities. We've also made an arrangement to mobilize the health workforce, the doctors and paramedical staff and lady health visitors from areas which are not affected. And we are hiring this staff from the market and through private sector and displacing them to the areas where they are badly needed these days. Another mitigation strategy is to involve the public in an awareness campaign, because I think this is the best way to mobilize people, creating awareness about the threat of these infectious disease outbreaks and sensitizing people to seek healthcare facilities attention whenever they have any problem, and to adopt infection prevention and control measures. We've also working on restoration of our vaccination and EPI program and increasing in the number of medical camps. We are offering medical camps and health facilities and temporary arrangements to all the affected areas, but obviously the number of medical camps are very less, and we need to increase them to have a better coverage of these areas. Another system that we are very proud of, that we have an efficient, active surveillance system for different types of diseases in the country, but now we have to establish an active surveillance system, particularly for these flood-affected districts as well. and provision of wash facilities in flood-affected areas. And because of the threat of the waterborne, vector-borne diseases like malaria and dengue, we need to have an ample supply of sprays, of nets, of mosquito repellents to save our countrymen from these deadly diseases. And another last thing that we need to work and focus on is the safe drinking water and food for the disaster relief. So there have been many organizations which are involved in providing safe drinking water and good, safe food for these camps, but I think these needs to be scaled up. So I will just finish my talk over here by just giving you an overview what is the situation and how climate change can actually lead to a disastrous situation like one that we face, and then ultimately leads to outbreak of different infectious diseases. And out of these infectious diseases, the neglected tropical diseases are of utmost importance. Thank you very much for your attention.
Thank you very, very much, Somia. That's a fabulous way to open this panel, giving us lots of ideas in those very challenging situations, from awareness to procurement, all the way to this safe water and nutrition. So thanks so much for setting the scene very clearly. I'll hand over now until our discussion. I'll hand over to the other speakers. And next up is Dr. Prasad Liyanage. Dr. Prasad, over to you. We'll be hearing more about El Niño Southern Oscillation and vectors.
Okay. Yeah. Thank you. Thanks again. And now I'm going to present today the influence of climate and local weather on diseases which we conducted in one of the highly dengue in Sri Lanka. So at the outset, I would like to mention my authors of this study, Dr. Iqtadar from the Ministry of Health and Niño Southern from the New York University School of Global Public Health, and Joaquin Bacchio from the University of Heidelberg University, and Hans Georgat from the Norwegian University for their contribution. So first, I would like to just give you an introduction to the dengue situation in the country. So dengue is first biologically identified in 1960 in Sri Lanka, and first dengue hemorrhagic fever outbreak reported in 1969. In the case with the rate of that high 9.9%, and there is we observed the cyclical increase in the trend of dengue epidemic in every 5 years. And we reported the worst dengue epidemic in 2017, reporting 840 per 100,000 cases, which is a rate of 0.24%. And you can see now it has become a significant public health burden in vector-borne Sri Lanka, not only the number of cases, but also the geographical extent of dispersion involving almost all the districts in the country. Now, if you look on the seasonal rainfall pattern in Sri Lanka, that Sri Lanka is a tropical country, you all know, and we have 4 monsoonal rainfall periods. First is the monsoon period spanning from March to April, and second, southwest monsoon is spanning from May to September, and second is the monsoon October to November, and northeast monsoon December to February. Those were the 4 monsoonal periods we experience, where the southwest monsoon is the most important, where we get the bulk of rainfall, mainly occurring and pouring the rain to the western portion of the island. And available evidence says that the El Niño condition shifts the rainfall pattern from southwest monsoon towards second winter monsoon, in which the southwest monsoon, that the period where we don't see southwest monsoon, during the El Niño season, that the rainfall is less. The probability of rainfall is comparatively low to non-El Niño years. And then it is shifting towards the second winter monsoon period, where there are higher normal, above normal rainfall patterns we can observe. So then that is shifting from May to September to October, November. So that is what the Meteorology Department says about the rainfall. That in relation to the El Niño. And here, our task is to describe how these weather influence these larval indices, and our primary intention of this talk based on our publication published in last very recently on the effect of El Nino on the indices, and with the evidence that we gathered from the publication is further supported by sequential analysis of Aedes, the indices to Dengue incidence, how they associated with, and then how the weather conditions are associated with Dengue, and also the public health interventions and their impact in terms of effectiveness and cost effectiveness, and also last but not least the mobility restriction, how the mobility restriction impacts on the Dengue. So all these evidence support our major component of talk today. So therefore, I will just give you an overview of that. I'm going to present the supporting evidence obtaining from the sequential publications, which intended and the publications are based on the same practice model. And the Aedes vector surveillance in Sri Lanka is a well-structured program led by National Dengue Control Unit, and it is supported by the anti-malaria campaign and by the units and medical research institutions. So for the institutions there, they take several responsibilities in surveillance in different components. And we have entomologists who are trained specialists in medical entomology, pointed to all the districts in the country. There are 25 entomologists in 25 districts, and they were supported in the field by field entomologists who are the people who have the basic training on doing the surveillance. And also public health inspectors, medical officers, and epidemiologists who are there in all the districts. They support, they supervise, they monitor the vector surveillance program. And regarding study setting, as I mentioned earlier, the western part of the country is severely affected by dengue, and Kalampu is the worst affected district. Next, the Dampa and the Kalutara, and we selected Kalutara district for this evaluation because it has very dense set of data. So Kalutara has 10 sub-district medical officer divisions, and each division has a sentinel vector surveillance site which surveys continuously the vector prevalence information monthly. So then again it has 18 rainfall monitoring stations and 3 temperature monitoring stations. So the data in this novel indices information we collected from 2010 to 2018. So each site was surveyed month to month. So we have 108 data points in 10 divisions, and also we collected information for promising index, contain index, and grow index. So then these were again developed in contemporary time series of representing each index value. And for the weather information, we collected daily rainfall and temperature data from the ground level mountain station under the Total of Department of Sri Lanka. And we took Oceanic Niño index as a measure of El Niño Southern Oscillation activity, and the data were obtained from the National Oceanic and Atmospheric Administration. So then the main region that we consider is the New York region. So we conducted the two-stage hierarchical analysis to obtain at the first stage we analyzed the effects of the association between the larval disease and the local weather, rainfall and temperature at each sub-district division. And then the second stage we used the association to obtain more robust estimation for the entire district while explaining the heterogeneity between these associations and different threshold values and their institutions. So this is the time series plot showing the monthly variability of the average of the indices and also the climate parameters, the vertical bar showing the rainfall and the horizontal line showing the container influenza index appropriation. So you can see the seasonal pattern is correlated with the rainfall monthly rainfall pattern, and this is the Oceanic Niño index El Nino and less than -0.5 La Nina. So then we have three major El Nino events and 4 La Nina events in the period. And what we can observe here is for taking premise index as an example, we see that this stock has the rainfall, monthly rainfall, is increasing monthly rainfall, the risk of occurrence of the vector in this vector, risk of identification of the vector in this and the difference is going to be higher with reference to the zero level of rainfall. So then extreme level of rainfall increase the risk and also there is a threshold of 200 millimeters per month for vector to increase. And that observation is limited to like of 0 months, and after increasing that, there is no such statistically significant association between the rainfall and permit index. So then it can be said that when there is some rain in this month, there will be increase in the activity, and this activity increase is proportional to the increasing level of rain. So the temperature as contrast to the rainfall has different kind of association because it shows that the lag of 1 month and 2 months has given rise to that significant association. There is no association as lag of 0 months and 3 months. So it again explains the dynamics of the activities with the response to the temperature, and development of the lower stages and maturity and the activity at the entire stage, all governed by the temperature. So the higher temperature exposure to the previous generations of the vectors, they are proliferating much more at a much more higher rate than the generation, and then the less 1 month and 2 month temperature would affect the present increasing vector activity. So then, if it is more than 35 degrees of Celsius, it is giving rise to a significant increase in the relative risk of inside the vector indicator. And more interesting, the oceanic Niño index. So then there is a lack of 6 months. You can see there is a very prominent increase in the relative risk of increasing the vector activity following the Niño index becoming more than 0.5, that is indicative of the El Niño condition. So start just a little bit increase in the lag of 5 months and it's more obvious at the lag of 6 months. And there are certain, La Nina conditions also showing little increase in the relative risk of dengue and earlier lectures. So in terms of consistency of these associations, then we can compare these 3 indices together with the rainfall, with respect to the rainfall, temperature, and also Niño index. So we can see that premise and decoy indices are behaving more or less in a manner, but the contained index has less sensitivity to the rainfall, but some sensitivity to the temperature, and also some fairly good sensitivity to the oceanic Niño index compared to other parameters. So then, again, this is what we can observe when comparing these indices, because the purpose of comparing these indices is that indices give slightly different information operationally useful. And I must say that associations of these indices are rather homogeneous among divisions, so that heterogeneity is not statistically significant. So here, it's going beyond the topic that we are under consideration. So I thought that we should provide some evidence based on the studies conducted in the same setting. So then this is how the Aedes larval diseases are associated with dengue incidence. So then in this slide we can see a lag of 0 months, how the permissive index behaves, lag of 0 months, how the veto, and how the contain. So again, this is comparison with these 3 indices, and these axes represent the deviation of the use index, and also this vertical axis represents the risk of dengue. So then the reference value is the lowest value of this range. So then we can see at lag of 1 month and lag of 2 months, there is a statistical increase relatively to the increase in the vector index value. So then when the vector index are high, or in other words, in a given setting that there is a high number of prevalence of the mosquito breeding, then the risk of dengue is becoming higher after 1 to 2 months into the future. So it is not very obvious in the contain index here that compared to the mosquito and permitting. So then operationally, what would be the value of this information? So then we have to identify what kind of institution or what kind of setting that the vector being high, because that is even though we do the predictions, even though we know the threshold value, so operationally we have to take actions based on the prevalence of these vectors by institution. So then policy decision can be made. So this bar chart represents the distribution of the vector breeding status we selected in 2014. I gave it for as an example. So then the breeder status, construction site, school, and then the private institutions have higher vector prevalence compared to houses. So that's a very good piece of information that we can transform into action. And also, not only the place, but also the breeding type. You start whether it is started with the rainfall review and covering items, so this is the prevalence. So if this graph, so in the 10 years data says that it is the high prevalence of the breeding state. And also the productivity, pupil productivity in the same, so then the covering items given rise to 93% of the intake. So then it is the most productive breeding state in this setting. So all these things are important for making the transforming this information evidence into action. So the key findings: the lag 16 climate and larval indices were shorter than those 16 climate and incidents, implying that vector control should be implemented earlier than previous studies suggesting in order to be effective. In the same month, the amount of rainfall appears to predict the magnitude of activity. Temperature and osmic index have the potential to predict the activity with 1 to 6 months lead time, and osmic index has added benefits of predicting the seasonal prevalence of Aedes vector with 6 months lead time. So how can we operationalize these things? How can we visualize these evidence into the operational perspective? So then this realization of the dengue epidemic is preceded by the larval disease by 1 to 2 months, and rainfall and temperature by 2 to 3 months, and El Nino conditions by 6 months. So these information are very important because these short-term interventions are mainly based on the identified breeding places, as I showed you in the previous slide. So for instance, if you see the covering item, so you can't just go and remove the covering item from the day that you serve. So it has to be done by some behavioral modification of the people. So it takes time. So it also takes medium-term and long-term intervention. The set of intervention is multi-sector participation, collaboration, and also bringing the engineers, bringing the social workers, bringing the experts from the different fields into the forum and making the discussion. That's the way that it has to be done. Otherwise, it is not sustainable. So then it needs time. So the El Nino rainfall provide some additional insight to plan and organize these interventions before it operationalized in a sustainable manner. So the climate change scenarios increase activity and dengue risk occurs with increasing temperature and rainfall and El Nino events. WHO roadmap for containment NTD by 2030 is a very good document. So we provide evidence on increased threshold. So these thresholds are used in context dependent and then specific to different contexts, or it is not the same threshold that we can observe, we can expect for all the other settings, so it is varying. And then we have to identify how to analyze the threshold in different settings and integrate into the action. And redefining vector control targets. It's not the household, but it may be the schools, workplaces, industrial zones, hospitals, and public spaces. We have this vibration. And for cutting it short, so we not only talk about dengue, so we just talk about the vector as whole. So we again avoid all the avoid dengue or Zika or whatever emerged or emerging diseases, so then we can all diseases have to have an integrated management approach, aiming for the vectors. So aiming the vectors is important, and knowing their biodynamics, knowing their prevalence, and knowing their impact from the climate is also very important. Early warning, we augmented with the location-specific information of vector activity. The 1 to 6 months lead time from the onset of weather events enables public health authorities to set up short, intermediate, and long-term goals for vector control intervention. So those are the main points that I would like to highlight. So we can take on the forum for the discussions, and I will happy to answer questions that arising from the audience. And thank you so much.
Wow. Thank you so much, Prasad, and also to the whole team of co-authors. That was incredible research and so many immediate and direct applications, and particularly in those all-important early warning systems that are really very useful and sought after in terms of resource planning and also disease control. So that was a fantastic presentation. Thanks a lot for sharing. We'll continue on the theme of vectors and vector control, and I'll invite now to share with us some findings. Invite Dr. Emma Maynard from the Wellcome Trust, a research manager in the Infections and Climate Department, who will be talking to us about building resilience to mosquito-borne diseases, this time through genetic biocontrol.
So thank you so much for having me here today. As mentioned, I'm Emma Maynard. I'm from the Wellcome Trust. I look after the infectious and climate area. Today I'll be speaking to you about building resilience to mosquito-borne diseases through genetic biocontrol. So a quick overview of who the Wellcome Trust are and what we do. We are a global charitable foundation with the aim of improving health for everyone by funding research, building global health partnerships, and advocacy to support science. We work with people and organisations using science to solve health challenges. We fund discovery research into life, health, and well-being, and we support research to find solutions to 3 key health challenges. These health challenges are mental health, infectious disease, and climate change. So I'm a part of the infectious disease team, and specifically I look after infections and climate. And to give you a bit of an overview of what the infectious disease team does, the infectious disease team's mission is to reduce the risk and impact of infectious diseases by targeting the factors that lead to escalation. This includes closing key knowledge gaps around sources and drivers of escalating infectious diseases through understanding the sources and drivers of the infections, shifting the thinking to recognise that burden is driven by escalation through undertaking early intervention leading to prevention, building an R&D ecosystem that can deliver solutions through creating affordable medicines and tools with equitable access. We really like to focus on communities most affected, so mostly the research we fund must benefit people in low and middle income countries. The mission goals and outcomes of the infectious disease team are supported by 4 key teams within infectious diseases. There's epidemics and epidemiology, prevention, intervention, and health systems and the environment, which is where I sit in. And this is where infections and climate fits in. So the infection and climate team strategy has a specific goal to see a reduction in the escalation and spread of climate sensitive infectious diseases in populations disproportionately affected. We'd also like to see an increased understanding of climate change as a driver of infectious disease escalation. So we will aim to utilise novel scientific tools and platforms to develop an evidence base for the impact of climate change on foodborne diseases, waterborne diseases, and vector-borne diseases, develop a portfolio of novel, affordable, and scalable vector control technologies, and to support the development of an enabling environment to ensure access to and implementation of these technologies. So one of the key diseases of focus for the infection and climate team is dengue fever, which is a viral disease transmitted to humans by infected female mosquitoes, predominantly by Aedes aegypti, and to a lesser extent, Aedes albopictus. Dengue causes a wide spectrum of disease that ranges from asymptomatic to mild or acute flu-like illness to severe dengue, which, if not managed correctly, can cause death. In fact, severe dengue is a leading cause of death and serious illness in Asia and Latin America. There's no specific treatment for dengue fever. Early detection and access to proper medical care does reduce the death rate from dengue. So dengue is without a doubt an escalating infectious disease. In fact, it's been referred to as the most important mosquito-borne viral disease with epidemic potential in the world. This map here was taken from the CDC and shows the current global distribution of dengue infections. The dots are showing where there have been recent reports of local and imported dengue cases. As you will notice, dengue is already widely spread throughout the globe. And for the past 50 years, dengue infections have been escalating. So since the year 2000, there has been over an 8-fold increase in reported dengue cases. And this now equates to about 390 million human infections per year. The World Health Organization reports that per year, there are an estimated 96 million symptomatic cases, which result in over 36,000 deaths. In terms of disability-adjusted life years, it's estimated that per year, dengue causes 1.9 million of them. And outbreaks and epidemics of other viruses carried by the same mosquitoes that transmit dengue have occurred across Africa, the Americas, Asia, and the Pacific. So this isn't just about dengue. There's also, for example, Zika and chikungunya, which are relatively new and have emerged in epidemic proportions. And of course, there's also yellow fever. So climate change is only going to further exacerbate this, with a predicted increase of global temperatures of at least 1.5 degrees by 2052. More and more areas and geographies will be suitable for Aedes mosquitoes. And this means that there will be a substantial expansion of areas where people are at risk of Aedes transmitted diseases. So dengue prevention and control centers around reducing the transmission, preventing outbreaks, and reducing morbidity. Currently, the main method to control dengue transmission is to control the mosquito, for which there are a number of methods currently in use. This includes environmental management, insecticides, and bed nets. But due to the current magnitude of dengue infections, solely relying on current vector control methods will be insufficient to interrupt the transmission of dengue. This is in part due to the mosquito responsible for transmitting dengue. The mosquito is able to adapt its behavior to breed in unconventional sites and small amounts of water, making environmental management extremely difficult. The evolution and spread of resistance to insecticides is a major concern for the control of dengue vectors. Bioassay data demonstrate that resistance to organophosphates and pyrethroids is widespread in Aedes aegypti, and resistance has also been reported in Aedes albopictus. Dengue vectors are typically daytime biters, therefore mosquito nets are less effective at preventing biting. Outside of vector control, as you may be aware, Takeda has recently shown some very promising results for a dengue vaccine, but we're not yet at a distribution stage, and reaching everyone with a vaccine can be difficult and time-consuming. As such, it's broadly recognised that there is a need for improved tools for vector control, as stated by the World Health Organization, which brings me on to genetic biocontrol. So there are a number of genetic biocontrol technologies that Wellcome has funded and continues to support. Additionally, there are another couple that we're in the process of funding. So this is how we sort of view the portfolio we have at the moment. So on the left, we've got supporting and funding surveillance efforts and creating an evidence base. This is to inform where and when these technologies will be needed. We also support the development of a number of different technologies for vector control. We have 2 Wolbachia projects, which includes the World Mosquito Programme and Stephen Sinkins. who work on Wolbachia mosquitoes individually. We also have Oxitec, who work on dominant lethal self-limiting mosquitoes. And we're also funding some work on gene drive. Underpinning all of this work is the enabling environment and surveillance to facilitate the implementation and rollout of these technologies. So it's important to note there are many other groups working on genetic biocontrol methods, both for dengue and malaria. But for this presentation, I'm just going to cover the ones that Wellcome funds on dengue. So as you'll have seen, we fund a number of different technologies. So you may be wondering, why not just one? And I like to think of it as creating a toolkit. So with almost every infectious disease, ideally you don't rely on just one method of control or treatment. This is because, as with any intervention to prevent the spread of infectious diseases, there are always pros and cons to each method, and they're often situation dependent. Some methods are more appropriate or cost-effective than others in different situations. And indeed, often they're best used or combined together to have the strongest effect and improve the efficacy. And again, as with the majority of infectious diseases, using a control measure can place selective pressure on the infectious disease to evolve to overcome the control. This has been seen with antibiotics and vaccines. Having multiple tools in the toolbox balances the risk of selective pressure and ensures that if this does happen, we have other options for control. We don't see a sudden massive escalation. So a bit more about some of the projects we fund. As mentioned, we fund 2 projects using Wolbachia mosquitoes. We have the World Mosquito Programme and also Stephen Sinkins. So Wolbachia is an inherited symbiotic bacteria, naturally found in 60% of all insect species. Infecting dengue mosquitoes with certain strains of Wolbachia blocks the transmission of dengue and also yellow fever, chikungunya, and Zika. Wolbachia is self-spreading and has cytoplasmic incompatibility. This means that if a male Wolbachia mosquito mates with a wild-type female, the progeny are not viable and will die. Only female Wolbachia mosquitoes can pass on the bacteria to their progeny. They're able to mate with either a wild-type male or a Wolbachia male and pass on the Wolbachia to the offspring, thus passing on the transmission blocking. The cytoplasmic incompatibility also gives a breeding advantage and therefore means that when Wolbachia-carrying mosquitoes are released, even on a fairly modest scale and duration, they're able to spread effectively in the wild, reducing the overall mosquito population and eventually replacing the wild-type population. The World Health Organization is supportive of Wolbachia mosquitoes and as such has recommended their use in the Vector Control Advisory Group. To highlight the effectiveness of Wolbachia mosquitoes, the most recent gold standard randomized control trial carried out in Yogyakarta by the World Mosquito Programme showed a 77% reduction in dengue incidence and an 86% reduction in dengue hospitalizations in Wolbachia treated areas compared with untreated areas. So we also support Oxitec, who've made the friendly male Aedes aegypti mosquitoes. The males carry a self-limiting gene, so when they mate with the wild-type females, the self-limiting gene passes on to the offspring. The self-limiting gene prevents any resultant female offspring from surviving. However, the male offspring survive and carry a copy of the self-limiting gene, which gets passed on to half of their offspring. Again, any females do not survive. As a result, the population of mosquitoes in the environment decreases by about 90% relative to untreated areas, thereby reducing the biting rate and subsequent transmission of disease. The self-limiting gene does persist in the environment but declines over time. So as you'll have seen in the portfolio overview slide, we're also in the process of funding some work that could be put into gene drive for Aedes aegypti. When you have just natural inheritance for any given gene, there's a 50% chance that a parent with a gene will pass it on to the offspring. With gene drive, which uses CRISPR methods to cause preferential transmission, the odds of passing on the gene goes up to 100%. So you can give a few mosquitoes an edited gene that then inserts or drives itself into all of the offspring. And over time, the engineered gene establishes in the population. So gene-derived technology is currently being developed for some Anopheles mosquitoes, for example, through the work that Target Malaria is doing. Wellcome are in the process of funding some work to develop genetic modifications that can be used for Aedes aegypti gene drive. Unfortunately, I can't give more details on the project at the moment as the funding process has not yet been completed. So how does the technology get developed and tested? The World Health Organization have developed a guidance framework for testing of modified mosquitoes. There are 4 key phases, and this is to ensure that risks are minimized and testing is done in the safest way possible. Phase 1 begins with laboratory development of the transgenic mosquito, and then proceeds on to initial testing via limited releases. This could, for example, be done by testing in outdoor cages. Then there's phase 3, which is using staged open release. And finally, ensuring the robust monitoring of the safety and effectiveness post-implementation. Progression to each step is stage-gated by decision criteria, which revolves around efficacy, safety, regulatory, ethics, and social acceptability. And critically, community engagement is essential throughout every stage of the project. So from the Wellcome side, as well as funding the development and testing of the transgenic mosquitoes, we're interested in how we can start to implement these extremely important technologies. This firstly involves understanding exactly where, when, and how to implement the genetic biocontrol tools. So this centers around setting up surveillance and establishing an evidence base. So this could include vector surveillance, climate and environment surveillance, genomic and metagenomic analysis, and also sort of vector modeling, climate modeling, environment modeling. And we're currently in the process of funding a project to start looking at this. Additionally, the enabling environment must be considered alongside consistent surveillance and monitoring. So the enabling environment is really a broad term, as you can see here by the list of things it could include, but will involve looking at establishing regulatory infrastructure for implementation, looking at how manufacturing and distribution will work, how to optimize the price and ensure that ministries of health are able to take up the product. This will be a focus this year within the Infection and Climate team at Wellcome, supporting the implementation of the technologies through contributing to creating an enabling environment. Thank you for listening.
Thank you, Emma. Amazing presentation, and we hear you loud and clear. Vector control measures won't be sufficient, particularly as the behaviors and the geographic spread of these vectors, very invasive vectors, continues to increase. So it's really great to hear about those very cutting-edge projects that you've mentioned, and also provides kind of a perfect transition to our next presentation that's also going to look at some mitigating tools in the toolbox to the impact of climate change on mosquitoes. And so thank you for your presentation. I'll hand over now to Delali Manto, speaking on behalf of Merck, who will be talking to us a little bit more about insect repellents.
Thank you. So once again, thank you to the ISNTD for this platform, granting us the chance to give some insights into the work we do with regards to the fight against malaria and the probability of its spread going extremely up in the next coming years. So first and foremost, I'll talk about who we are as Merck. So we're a global company of 60,000 employees across 66 countries. We've been around for more than 350 years, and our main purpose is to impact significantly human lives. We do this through 3 businesses: the healthcare business that delivers innovative treatments, also the life science business that empowers researchers with access to tools to do their work, and also the electronics business that continues to deliver innovative technologies. We are known globally as Merck, but in the USA and Canada, we are known as AMD Serono, Millipore Sigma, or AMD Electronics. To drive our global health activities, there is a dedicated unit at Merck called the Global Health Unit, where it's our responsibility to improve the health and well-being of those underserved in low and middle income countries through provisional access to Merck science and health, science and technology innovations. And we tend to do this collaboratively through the various partners that we consistently work with. So our global health strategic priority is basically to contribute to a number of SDGs where we would have significant impact. We do this across three arms. First and foremost, we do it through trying to work with countries to eliminate schistosomiasis as a public health concern, all in an integrated approach. We also work in low and middle income countries where we try and drive to prevent and control non-communicable diseases in these countries. And thirdly, we also catalyze innovative solutions for global health challenges. So what is our mandate at the Global Health Institute or in Global Health at Merck? It is to basically support the health needs of tomorrow. And we do this by addressing the upcoming global health challenges. So I'll basically focus on three major global health challenges that are being driven by three major factors. First and foremost, the explosion in population will definitely lead to an increased scarcity for the little resources that is available to us here on Earth. Water scarcity is also a factor that would definitely lead to global health challenges in the near future. And why we're here today, climate change. And some studies on some projections show that by the year 2050, almost half the population of the world would be exposed to the mosquito-borne diseases. So those are some things that at Merck Global Health, we take a keen interest and try to address these issues. So basically, we focus on strengthening the health system resiliency, all in a sustainable manner in these low and middle income countries. We do this in the capacity to prevent infectious disease transmission, and also increase where we work in their preparedness to event volatility due to climate change. We do this through a variety of means. First and foremost, through granting them access to the technological solutions that we have, and also permitting the adaptation to the set environment that we are in. We increase access to capacity through workforces and try and shape adequate policies to address some of these issues. We do not tackle diseases or health challenges as standalone problems, but we always do this in an integrated approach, trying to address the complete health challenges that are presented. We also are strong in predicting and helping the people we work with to be able to be aware of threats that are impending. And also we do this all through the partnerships that we build over time. So today I would be talking about our insect repellent and the work we are trying to do with that in the fight against malaria. I wouldn't go ahead to bore you with these numbers that the World Malaria Report reported over time, reported in their most recent report, having 200 million cases worldwide and the likes. but I'll move on to how we tackle the malaria burden globally. So we tend to tackle the malaria problem globally, as I said previously, in an integrated approach. We look at it in the regards of treatment, where there are drug discovery efforts and clinical development to explore new anti-malaria drugs in a preventive perspective. We also have programs that foster workforce building, and the focus here is with regards to proper and effective diagnosis of diseases such as malaria in the communities that we work in. We also have tools that help to access essential resources and strengthen capacities. And today my focus would be on our insect repellent, IR3535, which we are working to see its potential in the prevention of the bites of the Anopheles mosquito that causes malaria. So like I said, we tackle malaria as one in an integrated approach in Merck. So going back to the effect of what climate change may have in the spread against malaria in the very near future, I would hit on three aspects that we would need to keep our eyes on. So in the near future, probably around 2050, it's established that more places will definitely become suitable for malaria or mosquito vectors. So climate change will definitely lead to places that were less warmer now, and which will become more warmer in the future, becoming prone to the presence of mosquitoes and the ability to spread malaria. Also, with the climate change that is happening, with what the first speaker said, there would be a lot of floods and droughts, and flooding would definitely lead to more stagnant water and pools of water being collected in places, leading to suitability of breeding for these mosquitoes. Droughts would also cause where flowing water was to dry up and leave puddles and pools that would aid the breeding of the mosquito. Warmer climates would also extend the disease transmission season because the vectors would have a much more suitable environment to live, and therefore extend the disease transmission period. Temperature change can also definitely affect the behavior of the vectors. As we are seeing recently, the biting behavior of most of these vectors are becoming longer. Vectors such as mosquitoes are biting much earlier than they used to be. So there is the risk of more outdoor transmission happening now. And so therefore, it is imperative that we look at alternatives to address the problem of outdoor transmission, which is on the rise and definitely going to rise in the future. So that brings me into our insect repellent IR3535, which is intended to prevent the insect bites when used during outdoor activities. It's basically a safe alternative to DEAG. It has established excellent safety profile for use in all generations. So kids can use it, babies can use it, pregnant mothers can use it, the elderly can also use it. A single application provides protection for up to 8 hours on the single application. It's non-greasy, it's odorless, and it's fast drying. So you virtually have no feeling of it once you apply it. It's interesting to note that IR3535 has established efficacy against the Aedes mosquito, and therefore may repel mosquitoes such as the Aedes that transmit chikungunya, Zika, dengue, and the West Nile virus. It also has established efficacy against the ticks that carry Lyme disease. So in Ghana, we are currently trying to establish IR3535's efficacy against the Anopheles mosquito that causes malaria. We are doing this in a 3-phase study where the first phase would be carried out in a controlled environment in the laboratory to establish the efficacy or the repellency of IR3535 against the mosquito. We're doing against the Anopheles mosquito, sorry. We're doing this together with partners such as the Noguchi Institute and another partner called LIFO. I'm happy to say that in the first phase where we tested our IR3535 in a controlled setting in the laboratory, we did have positive results claiming and establishing its efficacy against the Anopheles mosquito in the lab setting. We are now preparing to move to the field to test its efficacy in real life use or in a natural setting. Then we would move on to a complete community-wide study to test its efficacy in the community at large. So in the next couple of weeks, we would be conducting the field study, and I'll keep you definitely updated on the results. So you would ask, why are we doing this? Why are we doing an efficacy study to establish the efficacy of IR3535 against the Anopheles mosquito? We want to have a claim against the Anopheles mosquito and thus malaria, and then begin discussions or conversations with the various country national malaria control programs to begin to see how best IR3535 can be a complementary tool in the fight against malaria in these countries. Once we have this claim, that is our intention to engage different NMCPs to have this as a tool and a complementary tool in the fight against malaria. Having this claim would also open up opportunities for IR3535 to be of regular use in the communities where malaria is endemic. And we plan to work with partners to set up some sort of a social business where, let's say, women in the communities would have the opportunity to sell these IR3535 insect repellents, first and foremost, to make a living, but most importantly, to establish or to prevent the transmission of malaria in their said communities. So going back to what we said we try to do at the Global Health Institute and wrapping up, we are providing new technological solutions to fight malaria or to test the efficacy of malaria and adapting it to the different settings or the different environments that we find ourselves. We are looking to shape policy, and we are addressing the malaria fight not just in one way, but in a holistic or an integrated approach. And we are doing this all in the efforts while building partnerships. Thank you for your time, and I wait for further discussions during our Q&A. Thank you.
Thank you so much, Delali. It's been very interesting to see all this development, and some questions are already coming in. A lot of very interesting product and tool, which is great news because as the public health sector kind of aims to respond to this climate emergency, from what we've heard from Emma, but also yourself, there's a huge scope and range of tools there ready to be deployed or nearly ready. So that's just a really positive thing. And kind of in that same vein, we'll now move on to our final speaker for this session, And moving a little bit away from vectors and vector control, I'll hand over to Professor Kishore Wasan and for the next presentation. And thank you again, Delali. And Kishore, you'll be talking to us about developing therapeutics and R&D for neglected diseases.
Well, thank you very much for the invitation to speak. I think my slides are up. I think.
There we go.
Perfecto. Okay, thank you. Thank you so very much for having me. Last speaker of the whole conference, I was able to see some of the other talks yesterday and the outstanding talks today. I'm Kishore Wasan. I'm a professor in urological sciences at the University of British Columbia and the co-founder and co-director of the Neglected Global Diseases Initiative at UBC. We started our initiative over 12 years ago, and we have over 300 faculty, staff, students, researchers involved in all different aspects of neglected global diseases, with our mandate being developing technologies and interventions at or below cost for developing world indications. My talk today is a little bit different, but it does build, I think, on what I heard from my colleagues in the last few presentations, in that the development of novel oral therapeutics to treat neglected tropical diseases that have been impacted by extreme climate events. And I'm going to give you some big picture principles that I think we can follow that can be applied to many diseases: dengue, Zika, malaria, etc. But I will also then go specifically into the work we've done with visceral leishmaniasis. But the principles that we're talking about can be applied to other mosquito-borne diseases, not just leishmaniasis. Well, everyone has seen these slides for the last 2 days. Number one is that rise in temperature that is happening around the world. But what's more important is that when we overlay this figure to the next set of figures, there's a correlation that everybody, of course, is seeing between temperature rise, mosquito-borne infections, and then the provocation of the disease and the proliferation of the disease as a function of these different changes due to climate change. So my colleague in the last presentation made the exact same comment that I'm making, that a mosquito-borne disease will threaten probably half the globe by 2050 and maybe even further. But I will also point out that even though we're seeing a huge increase in Africa, in India, in South America, we're also starting to see a big issue even here in the West, in the United States and in Canada. This is truly becoming a world problem and not a problem of LMICs. And I think that has woken up to the world to what we need to do to try to address this problem. So let's get practical. What is the influence of climate change on neglected tropical disease drug development? And there are a number of different issues that we need to look at, and there are potential solutions that we need to consider that have not been discussed, I think, so far today. So there is the hypothesis that's been out there for 20 years called the enemy release hypothesis. This hypothesis predicts that species will be successful in a new habitat when its former enemies are not present. And this has been widely applied to invasive species such as plants or animals in new habitats. I would extend this in that what is happening, I think, is that with climate change, we got parts of the world that normally never had these kinds of issues of infestation of insects and mosquito-borne diseases, but now we got a congruence of environmental events that have come all together that have now caused this mosquito increase in these regions that we never had before. And these other parameters include, of course, increasing temperatures, but it's more than just increasing temperatures. All right, it's the change of precipitation. It's the issues with drought and flooding. And we just saw that wonderful presentation about Pakistan. I have colleagues in Pakistan that have been directly affected by this, and it's horrible, 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 horrible what has happened there. We had recently problems in the United States. We've had hurricanes in Florida. We've had hurricanes in Mexico. that have caused huge devastation there. And the pictures that we saw from Pakistan, you could take those same pictures and show the same kind of devastation that we saw in mid-Florida, as well as what we saw in Mexico just recently. So this is a worldwide problem. Increases in humidity, increases in insect infestations. And another aspect that I think is really, really important and was highlighted by my colleagues is an increase in violent storms that has caused infrastructure damage and a big strain on our healthcare systems and our healthcare personnel. So even when we have these climate change that leads to these increase in violent storms, that leads to this infrastructure damage, how do we get medicines? How do we get therapies? How do we get preventative things to those people in those areas where they don't have infrastructure anymore? And it's hard to get to those rural populations with trained personnel so that they can be able to give medicines, have bed nets, do insect repellents, etc., so that we can treat people who are now going to be inflicted with these diseases because of this devastation. So from our perspective, one aspect that is really important is developing drug formulations, developing medicines that are cost effective, that are safe, that are tropically stable, that do not need a cold chain, that do not need refrigeration, that are accessible, and actually require minimal healthcare personnel for administration. Because now your hospitals have been destroyed, your health clinics have been destroyed. You can't be giving it's going to be hard to get trained personnel in sterile conditions to be able to give medicines and treatments to people in these areas. So you've got to now think about developing medicines that are easy to administer, that are easy to take, that you can store with you and make it accessible for the people that really truly need it. So I'm going to talk about one case example in our work with leishmaniasis, though then you can extend this, I think, to dengue, to Zika, to many of the other diseases that we've talked about today, African sleeping sickness being another one. So the latest in leishmaniasis is the following. Leishmaniasis is affecting millions of people around the world. It is probably underreported, and the mortality rate is close to 100%. And the way that leishmaniasis works is that there is a sandfly in poor sanitation conditions that stings you and releases a parasite that goes primarily into the liver and into the spleen, and that can cause systemic damage and ultimately death. And here's a map, and does this map look very similar to the map where we saw the temperature increase, to the map where we saw mosquito-borne infection increase? If you overlay those three maps, you could see a direct correlation between, the increase in temperature, the dramatic changes in climate change, the increases in violent storms, the increase in devastation to the infrastructure, the increase in mosquito-borne vectors, and now the increase in the disease. So it all correlates together, and we need to find a way to deal with this. At the University of British Columbia, we have a global access policy that we will develop technologies at or below cost for developing world indications. And we were the first Canadian university to sign on to this. And we've gotten international acclaim for our work in this area. What I'm going to share with you today is just one of the technologies that we have under this program. We have many different technologies under this program that you may want to consider and to think about. So what's amphotericin B? So amphotericin B is a Pauline macrolide antibiotic used in the treatment of bloodborne fungal infections and parasitic infections. It's a very effective drug. However, it has low solubility and low permeability. It has low oral bioavailability, and you have to give it by injection. And there are injection side effects. There's dose-dependent kidney side effects. The formulations up to now are not tropically stable, and there are a number of concerns. And these are the different infections that a wide range of infections that patients can get. A lot of them are immune compromised. Patients that have got HIV, uncontrolled diabetics, uncontrolled patients with cancer, but patients with COVID, patients secondary with other infections as well. This is quite a devastating set of diseases, and amphotericin B is very effective against these diseases. The current treatments of VL are really quite outstanding, but they do have limitations. There has been recent dialogue and exciting announcements from DNDi and WHO on the combination of liposomal amphotericin B and the oral drug miltefosine in treating VL, as well as a recent paper and recent excitement, the DNDi talking about miltefosine and paromomycin in the treatment of VL in East Africa, particularly in children. Exciting results, fantastic data coming out showing effectiveness. But unfortunately, there are still some limitations. Number one is you have to still use injections. In the case of liposomal amphotericin B and paromomycin, this really decreases accessibility. There are toxicity issues with these drugs, particularly paromomycin. It's an aminoglycoside. It has ototoxicity. It's very painful injection. Miltefosine is an outstanding drug. However, it has got what we call phototoxicity, which is in women with at childbearing age. And unfortunately, many of the people that are infected with leishmaniasis are unfortunately women in childbearing age and children themselves. So even though this is a great set of tools, there are limitations. And we need to find a way to address the issue of using injections from an accessibility point of view and using injections from a toxicity point of view. And what are the implications in LMICs? There is usually a loss of income, there's an increased cost of administration, there's an increased risk of side effects, and there's a decreased availability of treatment. So if we could develop an oral formulation of amphotericin B, all right, that has all the parameters that that I laid out at the beginning, that is cost effective, that is safe, that's tropically stable, that is accessible, and that does not need injections, that would be wonderful. And here are some of the advantages of that. All right, it'd be easy to administer. You can decrease the cost of administration. You don't have those injection or a lack of infusion related effects. There's a lack of kidney, liver, and GI toxicity. There's an increase in accessibility, and it's thermally stable. So if we can develop an oral formulation that addresses all these issues, we can get more drug to more people in poor endemic countries, particularly after a devastating storm because of climate change. And for future situations, we have something right there for the people. So here's some animal data that I'm going to share with you. This is a model. Our work was funded by the Consortium for Parasitic Drug Development, which is a subset of the Bill and Melinda Gates Foundation. And what was exciting is they had a standardized, validated animal model for leishmaniasis. They infect the animals with leash, and the treatment begins on day 7 post the infection. We gave our oral AMP BID for 5 consecutive days, and then we sacrificed the animals, and we measured the liver's weight and impression smears, and looked at the number of Leishmania amastogotes per liver cell nuclei, and to determine what was happening in our animal studies. And we got really quite amazing results. What I'm showing you here on the y-axis is the Leishmaniasis donovi. On the x-axis is the untreated control, the vehicle control, so that's our formulation without the drug. Miltefosine as a positive control. Ambisome, which is the IV parenteral amphotericin B that's currently being used, and then our formulation. And you can see that we had greater than 99% reduction in the VL load that was safe without any toxicity within 5 consecutive days. And here I show you a dose response study in the same thing, the Leishmaniasis donovi on the y-axis, our vehicle control, and then our oral formulation at different doses. And the bottom line is, at a dose about 5 mg per gig, which we will ultimately use in patients, and we can scale up and manufacture to be reasonable in patients, we have found that the very effectiveness without any toxicity. And this is a poster that we presented and published a little while ago. And I will have these slides available so you can look at it yourself. But the bottom line in this poster is we show the formulation stability at 43 degrees for 120 days at high humidity conditions. And that with this formulation exposed to those severe conditions and then treating our animals, what we found is a reduction in that in that parasite, leishmaniasis parasite, even after the formulation had been under that stressful condition. And so that showed to us that we had a tropically stable formulation that did not have toxicity and had significant efficacy against VL. Next, we did human studies, and we've done 2 phase 1 studies. These are human phase 1 safety studies. We've done a single dose safety study up to 800 milligrams of oral AMP-B, and then we did a multiple dose safety study up to 400 milligrams a day for 10 consecutive days in patients. And the bottom line is twofold. Number one, we did not see any kidney toxicity, liver toxicity, any GI toxicity, which is associated with the drug, as well as obviously we were able to avoid any injection systemic toxicity because we were giving it orally. And the other most important thing is we had a sustained systemic exposure of the drug. Amphotericin B is a very unique drug in that it's really not about its blood levels. It's actually about what we call the AUC, or the systemic exposure of the drug as a function of time. And so in this slide, and we show you right here that the blood levels in patients, we're able to maintain over a 24 to 48 hour period of time sustained exposure of our amphotericin B in the blood. And I won't go into the mechanisms why, but we are using a unique mechanism called lymphatic transport of drugs, which is a little more scientifically and techy for this, and a novel formulation that takes advantage of lymphatic transport of drugs and bypasses first pass metabolism. So what do we have here? We have a proprietary formulation that's with very affordable lipid excipients, the dollars per day or a few dollars per day. Ease of formulation, scale up, formulation stability for over 120 days, and drug stability at 43 degrees for over 120 days at very high humidity conditions. By the way, amphotericin B shows very little drug resistance out there. You can induce some resistance, all right, in the test tube. There have been some few cases, but someone will ask me the question, is amphotericin B having any drug resistance issues? And so far, in the broader community for leishmaniasis, the answer is no. There are individual reports. There are issues of drug resistance in animals, but like in dogs in Brazil, but not so far in patients. And that's why amphotericin B is still a gold standard in the treatment of VL. So what do we have, ladies and gentlemen? We have an affordable, easy to store, easy to administer, lack of kidney toxicity, lack of infusion-related side effects, lack of liver and GI toxicity formulation. And most importantly, it's cost-effective, it's safe, you don't need to have refrigeration. It deals with the issue of the climate changes that we're seeing, where, you know, what we assumed before we had in terms of infrastructure and changes in temperature and humidity and so on, we don't have that now, and we need to have products that can address that issue. As DNDi mentioned earlier today, we need more R&D to deal with climate change effects, and this is how we've addressed that with our formulation. So what are the advantages of the oral AMP treating patients with drug-resistant strains? We would be the first oral fungicidal agent on the market. We've got orphan drug designation from the FDA. We've got patents issued. And by the way, our patents are much more worldwide now. But for us, I'm not worried about making money here. I'm worried about getting it at or below cost for developing world indications. As I said, we are following our global access policy at the University of British Columbia, and we have positive human safety data and results. So I leave you with this last slide as a reminder of the improvements we had with the oral AMP. But I think I want to take away the big picture for you all here. And the big picture is this is just a case study of what you could do with other oral therapeutics for other diseases, for things like dengue, for things like African sleeping sickness, for things like malaria and other treatments as well, is that the same kind of approach that we've done here for leishmaniasis, you could apply it for these other diseases that are now propagating as a result of climate change. Thank you very much. I'm the last speaker of the whole conference, but thank you very much for listening to me. I've gone very quickly on purpose so that we have at least a little time for a discussion. And again, I want to thank Karim and Mariana for having me. It's always a pleasure and honor. It's very early in the morning here, so hopefully I've been able to keep my energy up. Thank you so much.
Absolutely. There was a lot of energy in that presentation, definitely. So if this is how you start off the day, I can't imagine what the rest of it will be like. So thank you for
lots of coffee. Lots of coffee.
My favorite too. But thank you for that. As you said, we've heard throughout this conference that the links between climate change and medical R&D aren't always very clear or really highlighted, and it's been wonderful to hear about your approach and your work, where the impact of climate is really embedded into how and you're going to go about and do this. So that's brilliant. Thank you so much. Thank you to all the speakers who've rejoined to perhaps take a few questions or just discuss a few points around everything that we've heard. I mean, some amazing research and innovations and really kind of solutions to this climate crisis, this one, probably the biggest threat to human health that's looming on the horizon. And so I suppose my first question, on the one hand, one can feel really kind of elated that there's so much going on out there in terms of trying to address this problem, but then still there seems to be a big gap between that and then actually having the solutions deployed or taken up by governments and municipalities. And so I suppose the first question I wanted to ask you is, how do you feel about that? And what do you feel are the main challenges ahead between the health sector becoming a really important partner and stakeholder in terms of combating and mitigating the impact of climate? What challenges are still out there that need to be overcome? I will probably just go in order of the speakers. So Somia, I don't know if you'd like to start.
Yeah, I think we still have to go a long way regarding the prediction of these disasters, which can lead to then health challenges, and also involving the health sector as a part of disaster management team. So for the immediate effects, probably there is more on, is there an echo?
Yeah,
can you hear me?
Come on. I'll just mute my microphone while you speak. Perhaps the other speakers could do the same. We'll check if that's helped.
Yeah, I think the health sector should be part and parcel of all disaster management problems. So talk about flood, talk about earthquakes, talk about global warming. They all in the future have a bigger impact on healthcare system of any community than economy or anything else. So I think the disasters lead to another disaster if they are not tackled timely, and healthcare is a part of tackling that disaster. So I think we should be more inclusive of making teams which have disaster management people, environmental control people, and health people working all together for the outbreaks which result from these disasters and the infectious disease spread. And because of typically we are talking about waterborne diseases today because they're part of neglected tropical diseases. So I think the planning and then the on the ground work and then the research, all these three components should be part of any predictive and then disaster management and then future policy of handling any climate related health challenge. Your mic is mute, Mariana.
So Mariana, amen. I agree 100%. I mean, we've been involved with some folks in climate change, for a while. And that's why our approach has changed, because once we learned about the issues that we're facing, we had to adjust our strategies from health product development perspective. but it would have been nice to been in the front seat with experts in this area in the beginning. So I agree. They should. We need pharmaceutical science researchers. We need healthcare professionals. We need people who are doing R&D right at the beginning of the discussion, and not coming in later on.
Right. So a bigger seat at the climate table. Prasad, did you have any thoughts on this?
From the beginning of this session, from yesterday also, we heard that the disciplinary and architectural approach in terms of serving the impact of climate change is important. And also, specifically looking into my context, and then I would say that sharing climate information with the sector and sharing the surveillance information with the climate sector would make some real difference in terms of identification of these transmission dynamics and also operationalization of the activities. And then it's not just to analyze the data, just to make a prediction. What's the most challenging is to reduce the burden at the ground level. So then for that, we have to have very sophisticated approach, but it should be friendly to the community as well. So then community participation in this whole process is paramount important, because ultimately that the community is suffering, and also that their ownership has to be transformed to the community. So for that, the infrastructure capacity building, the surveillance and the analysis, identification has to be come hand in hand, and also that the collaboration is the ultimate solution for the problem. Thank you so much.
Thank you, Prasad. So what you would like to see is, particularly in terms of surveillance data, is a lot more sharing of this data, and also the development of infrastructure and capacity building on the ground, presumably also to use this data. Thank you. Emma, did you have any further thoughts?
Yes, and I completely agree with what's been said already, that bringing together infectious disease data and climate data is really important. And I think something that's not necessarily been done so well yet. From the genetic biocontrol side, I think what's really important is having stakeholder engagement from the start, actually finding out what it is that the people who work in vector control really need, whether that's from the perspective of modelling tools and implementation, to actually providing the genetic biocontrol tools what it is that they want, I think is really important for implementing control measures.
Fantastic, thank you. Delali.
Yes, thank you. What I'd also like to add is that looking at the trend with regards to climate change and the big changes in the behaviors that, let's say, vectors or mosquitoes are having recently, and the upsurge of outdoor transmission, I think it's important that we look at alternative methods of tackling this outdoor transmission. So that's why it's important that we begin to look at some of these alternatives like repellents in that space, and also begin to have discussions with bodies like the National Malaria Control bodies and stuff, to also not just look at repellents as cosmetics, but also as an established tool in the fight against the upsurge of vector-borne diseases. Yeah.
Absolutely, thank you. Kishore, you added already something. Would you like to add something further to this?
No, I think that learning from each other what's going on is really critically important, but at a very, very early stage. So we understand the limitations that we're facing from day one, because if you develop a diagnostic or an oral therapeutic or a vaccine, my wife and I are doing vaccine research for whooping cough. We've got a grant to do that, so it's something separate from what I've discussed today. But knowing what the limitations that we would be facing in advance is critically important, because if we develop a technology and then we find that we can't apply it, we can't get it on the ground, then it's not worth to anybody. I mean, so it's really important to have all these people at the table. The other factor is, if I put on my healthcare hat on, I'm a clinical pharmacologist by training and been involved in a lot of clinical trials, is healthcare workers and getting them the training and expertise to deal with disaster situations, and being able to them understand what they need to do and what training they need to be dealing with a flood situation in Pakistan, or a hurricane or a typhoon situation in Japan, or etc. Because we don't get that in our medical education like we should. So I think that it's important to understand what's happening on the ground early on, and then have our people who are going to be in the front lines of dealing with those disasters, in terms of from a healthcare perspective, have the training and experience to know how to deal with that. And that's something that's still sort of missing, I think.
And it's great that you bring that up, because I was just going to turn to a great question raised by Swati Machikanti, one of our attendees. Thank you, Swati, for your question. So Swati's mentioning about large and looming challenge is that of ensuring that there's enough capacity on the ground. And I'm assuming that's in, again, the healthcare professionals. Would you have examples of how exactly the health workforce capacities are being adapted to be more responsive to these emerging trends? I'm assuming you mean maybe changes in trends in vectors, but also trends in climate and extreme climate events. So there's been a lot of discussion throughout this conference, indeed, in terms of research, bringing climate and health closer, whether it be in research or within organizations, or even at an international organization level. But going right back now to the local endemic regions, what about the healthcare force on the ground? And I don't know who would like to take that question first. Maybe.
Well, I would say, I don't mean to monopolize the discussion, but I would say working with local on the ground healthcare programs, healthcare institutions at LMICs, local governments, local clinics, is the way to address this. Several of us in Canada have programs in LMIC countries where we send our medical students, our nursing students, our pharmacy students to spend time in the developing world on the ground, learning, working side by side with healthcare providers to see what they're facing and the challenges are. The challenge that we have is going for 3 or 4 months and then coming home is not good enough. You have to make this a lifetime pursuit, and you have to stay there. And that's one of the challenges. So yeah, you can send a medical student or a pharmacy student or a nursing student to working side by side with someone in a local clinic in an LMIC community, but then they don't stay there, and which is a lifetime of sacrifice. But that's the sort of kind of things we need to do. Get your hands dirty, get on the ground, really understand the challenges you're facing, and then coming up with practical solutions to practical problems.
Great.
Yeah. I just wanted to add that there's always a scarcity of enough workforce on the ground, but we can overcome this challenge by having more leadership positions in the disaster management due to climate change by the healthcare professionals. So if healthcare professionals are part and parcel of the policy making related to all these things, probably they will be in a better position to advise these policymakers from the health perspective. So taking them on board and taking them in the leadership and positions, I think that's also very important, because they can make you aware of the effect of the climate change on the health. Because from the health perspective, if it's global warming, or is it heat wave, or is it flood related diseases, or is it air pollution, or is it smoking, everything in your environment ultimately affects your health, and how it affects our health, and what kind of diseases it will lead to, and what kind of medical relief would be required by the healthcare system. This can be assessed only by a healthcare professional who's dealing with it. So I think taking them on in the team, in the leadership positions by the policymakers who are dealing with the climate change problem is also very important if we want to overcome this problem in future.
That's great. And I think it is happening. I think definitely the movement of the health sector away from the periphery, a bit more central in climate discussions, is definitely happening and gathering momentum. We will see at COP27 where this goes. Last year, there was a great kind of coalition of health stakeholders who put together a statement and made a bit of noise around that. So we'll see how it goes. Those recommendations are well noted. Prasad, did you want to add anything to this?
Yeah, Marianne, still, I think the most needed setting, the climate change and health and the extreme weather events and disasters related to these events are limited to high-end discussion. And they were not penetrated to the operational level public health workers, like public health inspectors or midwives or any other community participants. So then there should be some mechanism for the public health task force development authority. They have to think and ahead, and they have to train, they have to incorporate these concepts into the basic training program. And also, a disaster response is very important. Disasters will be a big contributor to climate change, as we understood. So then the disaster management plan and disaster response should be preceded the disaster event, because we learned about the disaster once the disaster has happened. There's really no preparedness at the moment. So then it is very important for the public health task force to understand these problems, these principles, and their communication skills with the stakeholders has to be, because that is very, very important. Because two-way communication with the higher level authorities and communication with the community. So that is very, very important. Because I mean, we are not the people who usually communicate with the community. The public force is going to go and communicate with the community. So we cannot get capable enough to reach the exactly needed message. So then all the preparedness activities is in vain. So then I think that is my message. So develop the capacity of the public health workers, make them understand the impact of climate change, impact of the weather, and the importance of disaster preparedness. Thank you so much.
Fantastic. And I do invite everybody on this call to, when it is available, have a look at the recording of the previous session, which focused a bit more on the methodologies of bringing together the public health and the climate sector to really interesting approaches, one by a team led by Dr. Hannah Covert from the University of Pittsburgh in Dominica and Puerto Rico. It takes a lot of groundwork, asking each side, what do you feel is a priority, and just bringing that kind of dialogue together, a lot of community engagement. And also from Professor Dele Ogunseitan from the University of California, how do we integrate climate into health curriculum on an educational level? So very interesting approaches, to really translate what we're saying, but into actual steps on the ground or in education, in the training of the public health workforce.
Mariana, we were more focusing on the infectious diseases from the climate change point of view, but there's an equal chance of increasing risk of non-communicable diseases and mental health issues along with the climate change. So I think though our main focus because of ISNTD is on infectious diseases and neglected tropical diseases, but at the same time, we cannot ignore the fact that the non-communicable diseases and the mental health problems, they should also be addressed whenever we are talking about climate change leading to health crisis.
Absolutely. In fact, the brunt, I guess, of the climate and health discussion is around non-communicable diseases. Mental health remains very neglected, as always, but that's a very valid point. Delali and Emma, sorry, we haven't had a chance to come to you yet. You are both offering an amazing solution. What would you like to see more of, to see this adopted and deployed a lot more kind of realistically in a climate emergency scenario?
Yeah, so maybe I can go first. With regards to the repellents, basically repellents have been seen as quote cosmetics, or for people who go, tourists who goes to endemic areas and are normally in the outdoors, in the forest areas. But with the advent of the increase of outdoor transmission, I feel it's important that the education goes across to also make available or also give people the idea or the knowledge that there are solutions out there that can help break the transmission outdoors. So I think an educational push should come in the next days, or sorry, in the next years, to make the population more aware of some of these alternatives out there, so that we can really bring down the events of outdoor transmission. Yeah.
Fabulous community engagement.
Yes.
Emma.
I think as well, from my perspective, it circles back to community engagement and stakeholder engagement, sort of bringing the ministries of health on board, and also ensuring that there are systems in place that enable the technologies to be implemented. So I think a prime example is the regulatory environment. This is such a new area that we're working with. The regulatory environment is lagging behind. So we really need some capacity building, but also development within the regulatory systems to allow for these technologies to be implemented. But also, I think from the perspective of training on modelling and allowing people to critically evaluate the genetic biocontrol tools and actually have an informed decision of if this is something they want to use or not, and feeling they are able to make that decision.
Absolutely. I suppose you are a funder, so this may be a strange question, but funding-wise, is there a climate to support these? Is there a large appetite to fund these innovations?
So in terms of the development, or actually also the enabling environment to allow their implementation?
I guess both.
Yeah, so my Wellcome and also Gates are, I think, quite focused on this area of research. It's extremely exciting and has a lot of potential, and it's also been sort of to some extent endorsed by the World Health Organization, who've made a testing framework for genetically modified mosquitoes. So I think there is a big appetite there. It's quite an emerging and new control technology, so I think there's definitely scope for more uptake. It's an area we are really interested in funding and working on more, particularly looking at the implementation and enabling side. So yeah.
Super, thank you very much. Well, there's never enough time, and particularly squeezing a topic such as extreme weather event, climate and diseases into a couple hours is always a big challenge. But I think we've covered a lot of ground today in this session particularly, but also more generally in this conference. It's been really enlightening from right at the beginning, hearing from the WHO Climate and Health Unit about all these synergies and the next steps, and also just along the way, a lot of programs and thinking and also research that's it's becoming more and more second nature to think about public health issues in terms of the climate health constraints, and also enabling those in each of these sectors with tools and kind of a toolbox on how to approach all these very complex relationships in their work. So there will be more to come. This is just a beginning, and it's been a pleasure having everyone. I suppose before we completely close off the event, since you are, as Kishore was saying, the last panelists and the last presentations of the day, if you have any parting words for all our colleagues out there who are probably working in public health and really want to get more involved in climate advocacy, or just exploring climate research, or equivalently colleagues in the climate kind of sphere who want to integrate much more public health and a disease optic in their work, what would be your advice, having trailblazed kind of the way in this? Somia, perhaps you could go first.
Sorry, I don't know if you can hear me. Can you hear me?
Yeah, we can hear you.
There's something in the background which is...
Oh, sorry.
Oh, sorry. Okay, so I think it was a great initiative by ISNTD to take up this topic, that is climate and health. And the key to success for every, when it is related to health and otherwise as well, is the public awareness. So the more we talk about it, the more we educate our people regarding the issues of climate change on our health, and make them aware of it, the more we educate them, the more we make them aware, the easier it is for them to understand and for the policymakers to take it as the real issue. Because the actual voice comes from public. So if any issue is raised by the public, it obviously gets attention of all the decision makers. So educating our public and talking about climate change affecting our health is the need of the hour. The way we are talking about different diseases, we also need to talk about what is the root cause of these diseases. So we talk about waterborne diseases, but we need to know why there is an increase in the vector population. It is because of stagnant water, and the stagnant water is affected obviously by the flooding and pollution and artificial containers causing the breeding of the mosquitoes. Similarly, we talk about heat waves, and we talk about air pollution causing our health problems. But all of this is somehow related to the climate change, which is because of public itself, because of fossil fuel, because of increasing temperature, because of deforestation. So, conveying the message of cutting down on everything from the root cause is going to be helpful for our future generations. And this is the kind of message we should be delivering all across the world at different forums in whatever capacity we can, as a doctor, as a the drug discoverer, as a social activist, as a policymaker, as a politician, as some part of some NGO. And so if we spread this message and make people aware, I think we will be able to curb this issue and save our future generations from many of the health crises.
Thank you so much, Somia. I know we're in very safe hands and very dynamic hands with colleagues such as yourself. So thank you for these final words. Prasad, over to you.
Yes, thanks again. And then I think it is the impact of climate, extreme climate event or whatever the scenario is context dependent. Depending on the context, the impact varies. So I think we can't universally prescribe one set of interventions to our all the systems. So setting interventions are different. So the determinants are different. So then people have to have the capacity again to identify the risk of becoming, having some infection or having some disaster or whatever the adverse outcome. That there has to be some threshold defined based on the context. For instance, so if say that in our context, we have defined 160 millimeters of rainfall is a risk factor for landslide. So then how would the people know that there's a rainfall of 150? So it has to be, conveyed from the Department of Nature, so then that should take time. So then, these kind of things are still there in the community. They are the most literate people do not know how to understand or perceive the risk. So this risk communication again is a context-dependent methodology to identify the risk and communicate the risk as appropriate to people, as appropriate to the available resources, as appropriate to the activities that are there in the surrounding is very important for create an urgent and quick response from the community. Thank you very much.
Thank you so much, Prasad. And also, as I was saying to Somia, again, a very big thank you. You've been an inspiration yourself, and also your team of co-authors and colleagues. We've very much appreciated your contributions, so thank you. Emma, over to you.
I think just building on what the other two have said is we need more data and we need better ways of bringing the health data and the climate data together. I think there's something that we've seen is there's definitely a gap in ways of working together and data sharing. So I think that's one key element. And the other side, as Somia was saying, is talking about it, making people aware of exactly what's going on and why it's happening, and sort of really building the momentum with moving it forwards and making it a priority.
Thank you. Kishore.
Yeah, I was had to leave to go teach actually, and I was going to mention this in my lecture, but so I've got to leave in a minute. But I do want to mention one thing. It's great to talk about bringing people together and talking about how we're going to coordinate and collaborate with each other. But if we don't have coordinated resource allocations to make this happen, we're not going to move forward. And, I think that that's one of the issues is how can we work with private donors, foundations, companies, governments, etc. Everyone has a global health program in pharmaceutical industry, which is fantastic. Public partnerships are great. Product development partnerships are great. But we need to get people together in a room, not only to deal with the problems and understand a plan moving forward, but how to get the resources allocated to address those issues, because that is not happening. We're working still in silos when it comes to resource allocation. And if you don't have the resources and you work in isolation, you're not going to be able to move these problems and deal with these problems moving forward.
Fantastic, thank you. And I'd just like to add one other dimension, which has been put in the chat by Professor Oladele Ogunseitan, and it's a shame we haven't been able to have Professor Ogunseitan live, but next year that must happen. But I would like to remind you, we do have a very nice presentation from the previous session, so I will post that online. Look out for it on the ISNTD networks. Professor Ogunseitan says, I was just at the inaugural Steering Committee for WHO Health Workforce Office's Roadmap for Public Health and Emergency Preparedness. We need to start thinking of educating the workforce as part of the solution to the climate health emergencies. Competency-based teaching of healthcare providers is important for the recognition of symptoms in vulnerable populations. Absolutely. So education of the healthcare force, both in terms of diseases, but also climate impact, is very important. So if I had to summarize the last 2 days, I'd say it's very complicated, but at the same time, I feel like we've started to put order in all of the many, many facets and stakeholders and issues around integrating climate and health. And so I feel really energized and very positive moving towards COP27. We'll let the politicians get on with that and the high-level meetings. But I feel like as a science community, it's been really great to hear about all the research and the partnerships kind of on a basic science level. And that's been very inspiring and bolstered, I think, a lot of very positive momentum towards integrating climate and health. So for all those reasons, I'd like to thank you very much for what we've considered an extremely positive and helpful meeting. I just want to take a moment to thank my colleague, Cameron Rafiq. I think you mentioned him. We worked together on this a lot. He's not literally on screen, but he's behind the scenes. So a big thank you to him and to all our who supported the ISNTD. Thank you to all our amazing presenters. And of course to you, the fantastic audience who's tuned in at all hours of your day and from all over the world to join us. So on that note, I wish everyone all the best, and I hope to see you very soon, either at one of our more kind of regular events or this time next year for an update on climate and health. So on that note, thank you to all and take care, and we'll see you very, very soon. Thank you, everyone.
Okay, bye-bye.
Thanks, everyone.
Thank you,
Bye.
everyone. It was great to be here.
Yeah, great to see you all. Take care.
Okay. Bye-bye.
Bye.